Welcome to this session of Center for Podiatric Education. In this session, I'd like to discuss a real practical issue that all of us face, and that's the patient that presents with a Charcot joint deformity and whether or not there is a concurrent infection and whether there's concurrent osteomyelitis. Obviously, this is a difficult potential differential diagnosis in many patients, as the diabetic patient can present with an acute Charcot joint, Eichenholz stage 1 or possibly stage 2, and have redness and warmth and swelling, and they may have an associated wound. So we have some difficult clinical problems to examine. We have the patient who comes in with no violation in the skin or soft tissue envelope, and they seem to have an isolated Charcot joint deformity. We have the patient who has a Charcot joint deformity with ulceration. We have the patient who has a Charcot joint deformity and has soft tissue infection but not bone infection. And then we have the patient that has Charcot joint disease who has osteomyelitis. And the differential diagnosis here can be extremely difficult. The differential diagnosis in these patients is varied, and certainly there are unusual diagnoses that less common that can be associated with patients. For example, they might have an acute monoarticular arthritis that is not gout or pseudogout. But in general, the differential diagnosis from Charcot's joint disease includes cellulitis, whether they might have a thrombophlebitis, because frequently these patients have a swollen leg, swollen ankle, and not infrequently when we see these patients, they have been walking on this Charcot joint for some time. They typically have been evaluated at an urgent care center or by their primary care physician or a nurse practitioner or PA who is simply unfamiliar with Charcot's joint disease. They present with painless unilateral swelling, and typically they're sent for a Doppler. When that's negative, they're put on a diuretic. Meanwhile, they continue to walk on the foot, frequently contributing to deformity. And then finally, when the treating healthcare provider is unable to develop a working hypothesis for etiology, they refer them to the podiatric physician where the diagnosis is made. So certainly we want to rule out DVT in some patients, particularly if there's a prior personal or family history of coagulation disorders, perhaps a positive Homan sign or Prax sign. We want to rule out the possibility of an inflammatory arthritis. Most commonly in the diabetic patient, we're likely looking at gout or pseudogout. Certainly a fracture can occur, an avulsion fracture, a tendon or ligament rupture or other trauma can occur. We want to remember these patients are typically neuropathic. Pain may not be a major component of their pathology, and therefore we don't realize these patients do in fact have some trauma that has occurred and have an injury which we simply fail to appreciate. So these would be probably our most common differential diagnoses. Obviously, the history and clinical examination are followed by appropriate laboratory studies and bone and joint imaging. We know that Charcot joint deformities progress through 3, possibly 4 stages. I think most often reference is made to the Eichenholz classification system with acute disease in stage 1 and sort of a subacute resolving deformity in stage 2, and then residual consolidated deformity in stage 3. There are those who argue for a stage 0, of course, when the foot is initially edematous, perhaps slightly warm with an erythematous hue, but do not yet demonstrate any bone or joint pathology. The problem is when we have a wound that is present in the acute or subacute stages, Eichenholz 1 and 2. These are probably the most problematic situations given the fact that these patients have an open wound, they're diabetic, and they frequently have swelling and redness and warmth of their foot, so that from a clinical perspective, one would assume that this is likely a significant infection. So the examination of the Charcot patient typically includes unilateral edema with warmth, increased temperature, some degree of induration is frequently present. There may be decreased redness or blanching with elevation. The patient presents with neuropathy, and while we most commonly see this in the patient with diabetic neuropathy, we certainly see this in any disorder with which neuropathy is associated. And typically, but not always, there is an intact vascular supply, and it is a mistake to assume that Charcot's joint disease and vascular disease are mutually exclusive, because there are patients that have a Charcot joint that have evidence of peripheral vascular insufficiency. There is sometimes a history of trauma, and this is important to note because some patients do develop a Charcot joint following some type of sprain or injury. It's important that when these patients present to us with injuries, that we warn patients that while they have no fracture or dislocation at the time we're evaluating them, that this could trigger Charcot's joint disease, and advise patients to monitor their foot for increased warmth or redness, swelling, and if so, to immediately discontinue weight bearing and contact our office, or one out of an abundance of safety could tell patients, I want to reevaluate you in a month or even 2 months to assure that the patient does not have a traumatically induced Charcot joint deformity. The more difficult differential occurs when there's a break in skin integrity or a history of a prior ulceration, and we certainly want to assess the patient for any fatigue, malaise, fever, chills, tachycardia, tachypnea, or other signs or symptoms suggestive of the possibility of an infection. I think it is important to document the absence of these signs and symptoms in the patient with a Charcot joint, particularly in the presence of an open wound or ulceration. Frequently we see a classic ulceration below the midfoot, medial or a lateral aspect. We know that a fair percentage of diabetic ulcers are in fact infected, and if we look at patients with infection, a significant number of these patients do have an underlying osteitis or osteomyelitis. By osteitis, I'm referring to a Searney-Maeder type 2 infection where we have contamination or infection of the outer portion of the bone, or a very localized area of the bone, but not an aggressive, diffuse, total osteomyelitis. The longer an ulcer is present, and the deeper the ulcer, and the larger the diameter of the ulcer, the more statistically likely the patient is to have osteomyelitis. So here again, when there has been a delay in seeking care and the ulcer is larger, even though it is seemingly benign to presentation in terms of clinical manifestations of infection, I think it's important to consider the possibility of infection which may be occult, and it is important to document the basis for your decision making. We hear a lot about the probe to bone test and the reliability of that. Overall, the sensitivity is somewhat variable, although the specificity is much higher. And realistically, I think it comes down to your experience and the clinical scenario that's facing you in terms of deciding whether or not you believe that osteomyelitis is likely or osteomyelitis is not likely. So again, you're going to look at the clinical signs and symptoms, the presence of fever, drainage, malodor, the depth of the ulcer. You're going to look at the time the ulcer has been present, and you're going to put all this together and make a decision that it is or is not more likely. In looking at publications examining the probe to bone test, we do see quite a bit of variability in the sensitivity of the test, not so much the specificity, and therefore some variability both in the positive predictive value as well as the negative predictive value of this test. This was an interesting study published some years ago looking at the probe to bone test as well as radiographs. And the authors looked at patients with ulceration who had either a positive probe to bone test or x-rays that would be considered consistent with osteomyelitis, and osteomyelitis was considered to be present if either the patient had a positive probe to bone test or the patient had x-rays which were felt to be consistent with osteomyelitis. Using that as their criteria, 338 patients were evaluated. Of these, almost 3 out of 4 patients had histologically proven osteomyelitis, and of these patients, a little over 82% had positive bone cultures. And it was the opinion of the authors, therefore, that osteomyelitis could, quote, be diagnosed with confidence, unquote, if either the patient had a positive probe to bone test or x-rays consistent with osteomyelitis, or both the positive probe to bone test and x-rays positivities were present. Laboratory studies have been looked at in an effort to try to discriminate Charcot's joint disease from osteomyelitis, particularly in patients who have Eichenholz stage 1 or 2, where there are more inflammatory changes that are clinically present. Some of the suggestions that have been made in the literature include a sedimentation rate greater than 70 millimeters per hour being consistent with osteomyelitis. There are those who have suggested that a significant elevation in the C-reactive protein is suggestive of osteomyelitis rather than active Charcot's joint disease. Certainly acute phase reactants and acute phase hematologic changes such as leukocytosis have been suggested as perhaps helpful in differentiating infection from Charcot's joint disease, as we assume that leukocytosis is not a characteristic of Charcot's joint. And more recently, there has been interesting studies evolving with the use of procalcitonin, which is elevated early in the presence of infectious disease, and it is certainly hopeful that procalcitonin may represent a discriminating test of osteomyelitis versus Charcot's joint disease. Generally, procalcitonin will be elevated within hours of the onset of an infection, and certainly the average individual is felt to have less than 0.5 nanograms per milliliter of procalcitonin. 0.5 nanograms per milliliter is felt to be consistent with a local infection, and greater than 2 nanograms per milliliter felt to be consistent with a more significant systemic infection. There have been some early papers looking at the use of procalcitonin for the diagnosis of osteomyelitis. And this particular study looked at 24 patients with infected foot ulcers and also looked at sedimentation rates and the presence of leukocytosis. These authors concluded that in general a C-reactive protein was not particularly helpful. Significant elevations in sedimentation rate and white cell counts were felt to be consistent with osteomyelitis, and as you can see, patients without osteomyelitis tended to have lower procalcitonin levels than did patients with osteomyelitis. Biopsies through the open wound are somewhat controversial. Obviously, one can contaminate the testing culture approach through an open wound. In this particular study, 80 patients with osteomyelitis were studied. These patients were diagnosed by obtaining bone biopsy through the open wound. The studies demonstrated positive bone cultures in 96%, and half of the patients had received antibiotics within 14 days of the culture. These patients were treated based upon the results obtained by culturing through the wound, and the patients were followed on average for 17 months, and you could see that a significant number of the patients remained with a cure 1 year later. There have been others that have looked at culturing through sinus tracts, which of course is generally considered to be inappropriate. However, this particular study looked at cultures through the sinus tract taken at 2 different times. The concordance with the 2 sinus tract cultures was 96% with a sensitivity of 91% and a specificity of 86%, and it was felt that if culturing through a sinus tract revealed the same organisms, particularly Staphylococcus, and when those results were monomicrobial rather than polymicrobial, that the appropriate determination of the infecting organism and use of antibiotics could be determined in 94% of patients. These same authors reported a similar follow-up study, and again showing that monomicrobial concordance of these wounds cultures, even though they were taken through the wound, was reliable for determining appropriate treatment. Bone cultures in these patients with Charcot's joint disease can be obtained by needle puncture, by bone swab, and by bone biopsy, and the needle biopsy was noted to be accurate in 13 out of 20 patients, with a 16% false positive rate and 38% false negative rate. Now, in looking at the patient with a Charcot joint and an open wound and the potential for osteomyelitis, we certainly probably want to obtain bone for histology and bone for culture. In a perfect world, we obtain these cultures when no antibiotics have been administered for 2 weeks. An acceptable restraint in antibiotic administration would be 48 hours. Obviously, if a patient is septic, if they're hemodynamically unstable, if you have positive blood cultures, then it's going to be a bit more difficult, if not impossible, to withhold antibiotics. But in an ideal world, we want to go ahead and withhold antibiotics at least 48 hours. Personally, I tend to use percutaneous biopsy techniques under X-ray guidance when needed, such as using Jamshidi needles and similar types of devices. You always want to obtain both culture and histology because it is certainly possible to have a positive histology for osteomyelitis with a negative bone culture, or conversely positive bone cultures with negative histology. We want to remember that during Eichenholz stage 1 and early stage 2, the histologic characteristics of the bone are that of an inflammatory response, and therefore that inflammation will be consistent with either a Charcot joint or a bone infection. We've always been told that bone for culture and bone for histology is, quote, the gold standard for discriminating osteomyelitis from Charcot's joint disease. looking at histology versus microbiology. This particular study, published in Journal of Foot and Ankle Surgery, looked at 44 specimens of bone which were obtained for the purpose of determining whether or not osteomyelitis was present. The bone specimens were divided and half sent for histology and half sent for culture. And the authors were able to demonstrate that you were just as likely to have a positive microbiology study and negative histopathology as you would a positive histopathology and negative culture. So we don't want to rely on just a culture, we don't want to rely on just pathology, but our accuracy in determining whether or not bone infection is present is best accomplished by getting bone for both histology as well as for microbiologic study. This is the oft-quoted Meyer study in 2011, in which we examine the concept of a gold standard for bone histology. The authors noted that the diagnosis of bone osteomyelitis lacks a standard definition. So 4 pathologists were given 39 samples of bone. They were blinded to each other's opinions. The pathologists were told only that the bone was taken from a diabetic foot, and they were asked to evaluate the specimens for osteomyelitis. The pathologists in this study were restricted to one of 3 diagnoses. They could either say there is definitely no osteomyelitis, they could say that there's no definitive findings of osteomyelitis, but it could not be ruled out, or the findings were consistent with osteomyelitis. The pathologists only agreed in 1/3 of the specimens and had a significant disagreement in over 40% of the specimens, therefore sort of deflating this concept that bone histology is the end-all be-all, particularly given the fact that early on Charcot's joint disease and inflammatory arthritis are associated with inflammatory arthritis. So given that standard or lack of standard, if you will, when should we biopsy? Well, number one, we need to biopsy if you need to know whether the bone is infected, whether it is perhaps a tumor, perhaps an inflammatory joint disorder versus Charcot's joint disease. It is important to obtain bone biopsy when there is a risk of resistant organisms. So this may be a patient who is not responding to seemingly appropriate antibiotic therapy. It may be a patient who has had multiple exposures to antibiotics previously. It may be a patient that has a known history of MRSA or other resistant organisms. It may be that we have continuing bone destruction in the presence of therapies that we think were appropriate, and therefore we need to reassess the organisms present and reevaluate the potential diagnosis. And there are some who argue that if one is planning a reconstruction of a Charcot joint and we're going to be using some type of hardware, it may be medial or plantar or dorsal plating, it may be external fixation, we may be beaming, and under those circumstances we certainly wish to avoid the use of hardware in an infected area, and in those circumstances reconstructive bone biopsies and cultures would be appropriate so that we don't place hardware in an infected area. You can get in trouble on occasion even doing biopsies. This was a patient who had, in hindsight, a calcaneal pattern Charcot joint, and the typical tongue fracture pattern that we see with these calcaneal type Charcot joints. This was a patient that had a small plantar medial ulcer. The patient underwent a bone scan with technesium at the direction of infectious disease, which showed uptake at the attachment of the plantar fascia. And if you look carefully at this X-ray, you could see some early bone spur formation. I was consulted on the case. I did not think there was osteomyelitis. However, infectious disease insisted on a culture. I went ahead and did a Jamshidi biopsy from the lateral aspect. All of the cultures and histology specimens came back negative. Unfortunately, the patient went on to stress fracture through the Jamshidi sites. The patient then developed an osteomyelitis of the calcaneus secondary to the biopsy, and here we've debrided out the infected tissue and planted some antibiotic impregnated calcium sulfate beads. And my message here is don't ever assume that biopsies are always benign. Plan them carefully and realize that some risk does exist with even bone biopsy. Again, another study looking at the use of both histology and cultures for the evaluation of patients for osteomyelitis. And you can see from this study of 25 patients that 16 patients were histologically positive. 8 of those 16 were also bacteriologic positive for osteomyelitis, but no patient was double negative, so that the sensitivity of both culture and histology performed together was far greater than either just culture or just histology. So we are familiar with the unilateral swelling of Charcot's joint disease, most typically at a statistical level, the most common location being Lisfranc's joint, with this rather typical transverse swelling and redness of the foot. We see rather classic collapse at the level of the Lisfranc joint and in the mid-tarsal bones, again characteristic of Charcot's joint disease. Those who are familiar with this disease, primarily podiatrists and radiologists, look for the so-called 5Ds of Charcot's joint disease. We look at fairly normal density for the majority of the foot. We look for joint effusion. We look for fragmentation and debris. We look for erosion and destruction of the articular cartilage and dislocation. Again, typically at Lisfranc's joint or the mid-tarsal area, less commonly but still not rare, involving the subtalar joint, ankle joint, and even the forefoot, where we see stress fractures and metatarsal phalangeal joint reabsorption, so-called forefoot osteolysis. MRIs are helpful in the evaluation of these patients for osteomyelitis versus osteitis. It also helps us to discriminate Cirne Mater 2 from 3 disease. Sometimes we find that the disease is fairly focal and limited to one area of the bone itself. MRIs are helpful for looking for soft tissue defects and sinus tracts. We want to remember that osteomyelitis is a disease of a bone, whereas Charcot's joint disease is just that. It is a joint disorder, and it is not rare, unfortunately, for less informed individuals when confronted with these patients who have an ulcer, swelling, redness, and warmth, and are diabetic, to order non-specific studies such as a bone scan and state in the order rule out osteomyelitis, and the test comes back positive, suggesting osteomyelitis of 5, 6, 7, or 8 bones at one time, when in fact the patient is looking at not osteomyelitis but Charcot's joint disease. The differential diagnosis that we utilize MRIs for include just reactive marrow edema to the Charcot's joint disease itself, osteomyelitis, or osteomyelitis superimposed on pre-existing Charcot's joint disease. Classically, osteomyelitis is associated with increased T2 signal and decreased T1. We also want to look at the location of the changes and the fact that with osteomyelitis, we generally have a soft tissue defect with bone changes immediately adjacent to or contiguous to the area of soft tissue defect, as opposed to multiple joint involvement. Here again, suggestive of Charcot's joint disease. So with osteomyelitis, we have bone destructive changes immediately adjacent to, immediately contiguous to the soft tissue defect. Again, those familiar with patterns of Charcot's joint disease know that typically we see certain repeated patterns and repeated deformities. With classic Charcot's joint disease, hopefully we have no contiguous soft tissue defect or ulceration. When we have acute infection superimposed on Charcot's joint disease, the typical sequence being swelling, redness and warmth, then progressive deformity, then the development of an open wound or ulceration, whereby the differential diagnosis becomes more difficult. We just see diffuse bone marrow signal abnormalities, progressive subarticular enhancement, and loss of the subchondral definition with subchondral cysts. So typically with osteomyelitis, here illustrated is a rather typical midfoot Charcot joint deformity with collapse at Lisfranc's joint, subluxation planarly of the cuboid, development of an ulceration, and then marrow changes restricted to the area of the cuboid. So this would be representative of a prior Charcot joint, which has collapsed, created pressure, broken down the skin, developed an ulcer with secondary infection. And again, MRIs are helpful in many respects. They're useful for identifying abscess formation. They're helpful in showing polyarticular joint disease consistent with Charcot's joint disease. They're helpful in looking at and isolating the soft tissue defect and looking at details of the bone immediately adjacent to that soft tissue defect. An example of a patient with ulceration, foot deformity and collapse, and isolated marrow changes within the cuboid suggestive of osteomyelitis. This can be enhanced with gadolinium and contrast enhancement of the findings to further demonstrate the presence and extent of the bone infection. We may have situations on MRI where a sinus tract is present through the ulceration, but we have no adjacent bone marrow changes to suggest osteomyelitis. Again, the so-called ghost sign, in which the characteristics of the infection are enhanced with the use of gadolinium. In this day and age, of course, a variety of advanced radiographic techniques are available, including PET scanning and white cell imaging. This particular study looked at FDG PET scanning with WBC imaging in the diabetic foot. Not a particularly large number of patients, but a reasonably done study nonetheless. The criteria included an examination of target to background ratios for the WBC scanning, and the authors concluded that really FDG PET scanning had low diagnostic accuracy for osteomyelitis, and that actually white cell scanning in this particular study appeared to be superior. We've had increasing interest in dual isotope SPECT-CT imaging, and again, this has been shown to have some degree of accuracy for the diagnosis of osteomyelitis. In looking at the diagnosis of osteomyelitis in the Charcot joint patient, there are those who have established criteria as osteomyelitis being definitely present, greater than 90% probability, probably present between 51 and 90% probability, possibly being present with a 10 to 50% probability, and being unlikely. So given an ulcer, given a Charcot joint deformity, we can characterize the findings as representing osteomyelitis as definite, probable, possible, or unlikely. Definite osteomyelitis, that is to say greater than 90% likelihood of bone infection, is considered present when there's a positive bone culture and bone histology, or we see pus coming from the bone in the operating room, or we have MRI findings with classic presentation of an intraosseous bone infection and abscess, or we have two probables, or one probable and two possibles, or four possibles. The probables, two of which make for likely osteomyelitis, include the presence of bone observed within the ulcer itself, an MRI with bone edema or other changes of osteomyelitis, a positive culture with negative histology, or a positive histology with negative culture, or any two of the aboves. Possible osteomyelitis are those patients who have positive x-rays consistent with osteomyelitis, or an MRI showing bone marrow edema, or a positive bone to probe to bone test, or visible bone within the ulceration itself, a sedimentation rate greater than 70 millimeters, or a non-healing ulcer greater than 6 weeks, or an ulcer greater than 2 weeks with signs and symptoms of an infection. Osteomyelitis is considered unlikely, but still possible in up to 10% of patients where there is no sign or symptom of inflammation, where we have a normal x-ray, where the ulceration has been present less than 2 weeks, if it is a superficial ulceration, where we have a normal MRI, and where we have a normal bone scan. Lastly, a few words about antibiotic therapy. We know that overwhelmingly the majority of patients in the United States are going to be treated with bone debridement, bone resection, frequently some stabilization with external fixation, and a course of 6 weeks of parenteral antibiotics at a bactericidal level. However, if we look at studies on the treatment of osteomyelitis, we know that oral antibiotic therapy is equal to parenteral antibiotic therapy. There are some caveats involved, and that means that we have to use antibiotics that have good bone penetration, and we also want to assure that there's adequate vascular supply to allow sufficient perfusion of the antibiotics into the bone. In treating osteomyelitis, although the standard in the United States remains 6 weeks at a bactericidal level, the optimal length for antibiotic treatment for osteomyelitis still remains unclear. We have no evidence that therapy at 6 weeks is better or worse than therapy for a greater length of time or shorter period of time. And we know that local antibiotic therapy can be effective. With regard to chronic osteomyelitis, we know that there is a recurrence rate of between 20 and 30%. The recurrence rate which is associated with osteomyelitis is not dependent on whether oral or parenteral antibiotics were given. And there's no support for this concept of chronic suppressive therapy, where we administer drugs such as doxycycline, or other drugs for prolonged periods of time in order to reduce the frequency or intensity of those infections. As far as surgery goes, I believe the majority of individuals in the United States will direct surgical therapy initially at infection control, try to establish as best one can that the infection has resolved, and then secondarily go forward with reconstruction when necessary. However, there has been recent literature advocating one-stage treatment of the infection by resection of the infected bone and external stabilization and reconstruction of the foot, together with tendo-Achilles lengthening. So in summary, this is a very difficult